You can. I was going through the recording some. Of course, I might later on edit them so that unnecessary conversations are removed. But otherwise, it is coming very clear and very voice is very clear. So is the this one. Now, see, we are going slowly on immunology, the immunization, because I feel that your knowledge of immunization is vital, not only from the examination point of view, from the practical point of view. That is why I'm going very slow in it. And the majority of the points in immunization I have taken from the IAP to the Purple Book, that is 2022, which is the latest book on immunization. But some points I have taken from WHO position papers. And the third preference, I give it to CDC when you don't find much. And maybe some journals or something. I have not taken much from textbooks because most of the textbooks I've taken from the Purple Book only. Now, my question to you is very practical. Maternal immunization. I think, Faris, we discussed it last time, therefore I leave you out. Lasima, maternal immunization, what all we give to the mother? What all?
Sir,
Yeah, tell me.
sir, Tdap കൊടുക്കും.
Hmm.
Live vaccines are not recommended with exception is rabies.
Okay. Actually,
Mm.
rabies vaccine is not live. It is a attenuated vaccine. We discussed it with last time. It is not a live vaccine. Okay, carry on. Then,
Flu vaccine we can give.
yeah,
Mm.
Tdap and flu, and that's all. Some people talk about a hepatitis B injection and all that. That's we are not interested. I think these are two vaccines.
Varicella.
Well, varicella is a live viral vaccine. You can't give it during
Yeah,
the.
you can get. Yeah.
Yeah, you
Sorry, sir.
can't give it during this one. See, you said that we will come to that later. We won't be discussing about influenza vaccine. But remember, when WHO states influenza vaccine, number one priority, they say is maternal. Maternal. Number two is children up to 6 months to 2 years. Therefore, maternal immunization with influenza is supposed to be very important. Now, suppose somebody asks you, Doctor, should we give Tdap or not? In fact, Dr. Ananda Madam asked me this question when I was joining at that time. And she said, I am not interested because why are they coming for Tdap afterwards? And the vaccine actually, if you give, you know that tetanus toxoid is no longer available, only TD is available. And it is costing about 50 or 80 rupees, while Tdap will cost you some 1,200 rupees. So she was asking me, why should I give such a costly vaccine? Is Tdap indicated or not? I'm just asking you, most you people have been in the ward for so long, your relatives, your children, your family also, they may ask, doctor, should we take it or go to a private? Because only the private institutions give Tdap in the maternity. I don't think they give in the government. So
Now
naturally,
routinely Tdap is giving, sir.
huh? What's it?
Tdap is now giving.
In the government sector also?
No, sir, private.
Private, yeah, I'm asking you. Therefore, your relatives may ask you the question, should we be giving Tdap? Should we are taking immunization from the government sector. We are quite happy about it. But should we be giving, or the gynecologist, obstetrician may ask you this question because of the simple reason that if you go to the I don't know whether you ever went to the immunization clinic when you got time and saw how intradermal injections are given, etc. If you go there, I would like to talk in English as much as possible because this is getting recorded and multiple people are observing it. Therefore, I don't want to talk in any other language as much as possible. Now, the question is, if you go to the immunization clinic and ask them, you will find some patients are sent for Tdap by half the 50% of the gynecologists. Another 50% they don't send it for Tdap. And there are many obstetricians who have asked me whether this should be given or not. But now probably they have their own guidelines, and the majority are shifting towards the Tdap vaccination. Now, if I ask you, should it be given or not, what will be your answer? Because I am asking you upfront all these questions, you should have known the answers by this time. What do you say, Lazima? Mohsen, can you tell me? You are a senior PG now.
Yes. Yes, sir.
Yeah, why? What is the reason why Tdap is so much advocated?
മൂന്നും കവർ ചെയ്യും സർ പെർട്ടോസിസും കൂടി കവർ ചെയ്യും
Yeah, talk in English. The answer is it covers pertussis. Pertussis can happen in the newborn period, and it is supposed to be highly fatal. You know, even in Western countries, fatality is very. If you have a newborn pertussis, that's the end of the story for the child practically in that time. Newborn chickenpox also used to be the same thing, but now we have acyclovir and some of them do survive. Therefore, this is not protected by the newborn vaccinations because it starts only at 6 weeks, and you can't give a kill vaccine at birth because it won't work. Therefore, the only way is to immunize the mother. Now, finally, before I come into these things, I hope you don't have to. The question is, how do you? I had asked you previously, how do you diagnose tetanus? I am not going into that. How will you diagnose a newborn whooping cough? Tell me, because you have to make the diagnosis. The mother may not come and tell you my child is having whooping cough. She might just come and say he's having cold, some cough at times. Newborn's cough also is not that common. How do you diagnose a newborn or even a child below 2 months having a whooping cough? What clinical feature will make you suspect it? Because if you leave it, anybody can answer that question? Ashwati? They say your eyes will see only what your mind knows. This is very critical, because you patients, you doctors are not seeing infectious disease as we saw. We like polio. If you see a polio, will you diagnose? Maybe you will, because they come usually with paralysis. You will send to a neurologist. He will diagnose even if you don't. Tetanus, I don't want to bypass into that, but whooping cough, I want to ask. Newborn whooping cough. If you don't diagnose, nobody will diagnose. But what will be the feature, doctor? Lasima? Anybody can answer. Well, Devika is there on the line. Can Devika answer that question?
Sir, I couldn't see the question, sir.
No, it is a verbal question. We have not started the presentation. You can this question
Oh, okay,
is
sir.
maternal immunization. We are telling we give Tdap. All our people want to give Tdap. I asked them, is it necessary? They said it is necessary because you want to prevent, especially whooping off in the newborn period, because it carries a very high mortality. My question, Devika, is you are having a DCH, you have been, I think you have a lot of experience also. How do you diagnose whooping cough in the newborn period? Because you must diagnose whooping cough before the whoop develops even in a child. Because the whoop develops after first week or second week. By the time he would have infected many other people. And one thing you must understand is among the DPT, among the diphtheria, pertussis, and tetanus you give, the least effective vaccine is the is the whooping cough vaccine, which is only 60 to 80% effective. Therefore, you can get a whooping cough in an immunized child. It is almost impossible to get a diphtheria in a fully immunized child. Tetanus also is very, very rare. Now, if you get a whooping cough in a newborn baby, now since you are not answering, I am telling you it's not that easy. What happens is mother never comes to you with telling whoop, because there is no whoop in newborn period. What does she come? She says the child, doctor, suddenly becomes blue or suddenly becomes apneic. Apnea is a presentation in an 8-month-old. He has a slight running nose. But then when you ask them, is there a cough? Yeah, because how much can a newborn baby cough? So what in the point will make you diagnose whooping cough in a child, newborn baby? Devi, I'm asking you this question to you. There's a very important question
Yes, sir.
yeah. Infectious disease is a very important question you should ask. It is as important as doing an MRI in a child, let me tell you, in a neurological case. That is what will make the diagnosis. See, whenever you have fever in a child, the child fever lasts 3 days, 5 days, you're worried whether this is a viral fever or bacterial fever. The first question you should ask anybody in the family having fever. If the child is in at home only and not going to a nursery or anything, nobody having fever or cold or cough at home will make you suspect probably it is not viral. But if he's going to school, you can't take. Contact history is very important. Therefore, the first question you would ask is the mother having cough? And then she say, oh, that has started 1 month back, 2 months back. Are you having a whoop? You ask them. Sometimes it will be there, sometimes it won't be there. Therefore, the contact with the mother who is having a prolonged cough, if you have a whoop, it's great. And then the child developing any respiratory symptoms, you straight away diagnose it as whooping cough. And the funny thing about whooping cough is the child is, during the whoop, he's very, very sick. He might have apnea, cyanosis, and he might even die. Even not even die, untreated, they die. Nowadays, with PICU and ICU care, they might survive. In our times, 100% mortality. Now, if you, the moment you know that the child has, and in between this cough, at least initially, he will be absolutely normal. That is, he will take his feeds, he will not have a high fever. Maybe he have a running nose, not much of a problem. But suddenly when this comes, it becomes very sick and you suspect it to be a whooping cough. That's a great suspicion to make, because if you keep the child, send the child home, he might die at home. That's the reason. Now, you can see the slides. Therefore, I'll start maternal immunization. Today, it's not only Tdap. We'll go through it fast. Okay. Now, can you read it fast now? Mohsen, can you read?
Yes, sir.
Yeah.
Immunization in pregnancy. Live vaccines are generally contraindicated in pregnant women. A yellow fever vaccine should be avoided in pregnant women as far as possible. However, if travel is unavoidable, the vaccine should be given as the risk of infection outweighs the risk of vaccination, preferably in the first trimester. Measles, MMR, and varicella vaccines are contraindicated in pregnancy, and pregnancy should be avoided for 4 weeks after vaccination. However, routine testing for pregnancy prior to immunizing with these vaccines is not recommended. If the vaccine is inadvertently given during pregnancy or pregnancy occurs within 4 weeks of vaccination, termination of pregnancy is not warranted. Small cohort studies show no increased rates of congenital abnormalities in infants born to mothers inadvertently vaccinated in pregnancy. Measles, MMR, and varicella vaccines can be safely given to contacts of pregnant women, as these vaccines do not spread from vaccine to contacts.
Yeah. You can give it to pregnant contacts, but which vaccine cannot, live vaccine cannot be given to contacts of pregnant women? They said measles, MMR.
Varicella.
Huh? Yeah, this can be safely given to
Varicella.
contacts. If you have a pregnant woman, see, these things will not go through your mind. If you are a good pediatrician, you should go through it. You must elevate your practice. People think in day-to-day practice, academics is not important. How many people have asked that when you vaccinate a child, is there somebody else who's pregnant at home? How many of you have seen measles? They say no problem because it can be safely given to contacts of, it's not pregnant women, contacts of pregnant women. And the question is, which vaccine should not be given to a contact of a pregnant woman? Live vaccine, which we normally give. Remember, live vaccine which we are giving is MMR and varicella. That's the most common things which we are giving. There is live typhoid vaccine, there is live influenza vaccine, there's live hepatitis A vaccine, but they are not so commonly given by us. And herpes zoster is another vaccine which nowadays is being given for children, patients above 50 years. for senior citizens. We will come to that vaccine carefully. That means it has never crossed your mind. You would have given it 100 times to children. You would have never asked whether there's anybody pregnant at home. We'll come to that later. Okay, go ahead. Last sentence, has it come up? Anyway, smallpox vaccine is the only vaccine known to be harmful to the fetus. Can you read the line now? Yeah, next. This is general introduction to maternal vaccine. Tell me, has the slide changed?
No, smallpox vaccine.
Okay, read it from the
Immunization. All inactivated vaccine may be safely given during pregnancy. Important are TD, TT, or Tdap vaccines.
IIV inactivated influenza vaccine.
Inactivated influenza vaccine and hepatitis B are other vaccines of importance in pregnant women. Pregnant women should not be given live activated influenza vaccine.
Mhm.
A rabies vaccine should be administered to pregnant women if indicated and is safe. Passive immunization with Ig containing preparation is safe in pregnancy. All pregnant women should be evaluated for immunity to rubella, varicella, and hepatitis B. And those found susceptible should be vaccinated immediately after delivery. All pregnant women should be tested for hepatitis B virus surface antigen, and if found HBs positive, should be followed carefully to ensure that the infant receives HBIG and begins the hepatitis B vaccine series no later than 12 hours after birth and completes the recommended hepatitis B vaccine series on schedule.
Now, please understand there is a sentence here. All pregnant women should be evaluated for immunity to rubella, varicella, and hepatitis B, which we don't do. I don't think anybody does it here. Therefore, if any hospital they start doing it, don't blame them. It is given in the purple book of guidebook of immunization. You might say, "Oh, this is not important." But if you have seen a congenital rubella syndrome or congenital varicella syndrome children, and if you have seen a hepatitis, hepatitis now we prevent very well. Rubella and varicella, I have seen only rubella 2 or 3. Varicella 1, I have seen this was a child, son of a nurse. Very, the amount of suffering that it brings to the family is enormous. And when you know it can be prevented, is something bad. Therefore, wherever you are working, if it is in a good hospital, see, is antenatal care is not to be simply followed what the government says. When the patient comes, they are able to afford this, worth it, doing the rubella, varicella, and hepatitis B, especially rubella and varicella titers. If they are negative after the delivery, you can give. This is not a practice which is done anywhere, but I have not seen it being done anywhere. But it's wide wherever you start practicing. Suppose you go tomorrow to KIMS or some other place, you can talk to the gynecologist and say, look, this is evidence-based practice. Yeah. Now we go to the maternal Tdap. So far we were talking generally about immunization. And finally, you didn't answer me. Is there any point against maternal Tdap? Any point? If you ask Dr. Snehabalan sir, he'll say, no, I won't give it. There might be some reason why he says that. Change is something not very easy. It's not a live vaccine, it's a killed vaccine, my dog. Why is it called Tdap? T is capital, D is small, AP is small. What does it mean? Why is T given in capital letters, Lasima? While just because it starts the name or what? What do you mean BT? T is full dose, adult dose. D is not the dose which you give for a 6-week or 10-week-old child. Its dose is low, LF units is low. AP vaccine, it is not the same. It is a low dose AP vaccine. Anyway, now you read it. Okay, read through this if it has changed.
Maternal immunization to prevent infant pertussis. Among all these strategies, immunization during pregnancy appears to be most effective strategy to have the most impact on infantile pertussis, especially during the first few weeks after birth. The effective transplacental transmission of maternal pertussis antibodies should protect the infant against pertussis during the first month of life. The transplantally acquired antibodies may be detectable at least up to first few weeks of life, the age at which the first pertussis containing vaccine is due. However, the concentration of antibodies required for protection against pertussis in newborn is not known. In 2011, the Advisory Committee on Immunization Practice recommended a dose of Tdap to all pregnant women after 20 weeks of gestation to provide protection for both the mother and her newborn during the infant's earliest week of life.
It's a very important statement. You understand? That is not only to the child, to the mother also. This is given by the Advisory Committee of USA, the Indian Academy of Pediatrics. I don't know whether they have said it. We'll come to that later. The only thing I would like to say here is everything is very clear to you. Suppose some mother comes and says, Doctor, I have been taking vaccine and I don't want to take vaccine when I'm pregnant because we don't know whether it will produce congenital anomalies. Therefore, would you like to give it before pregnancy? What will you say? If Majida comes and says, give me Tdap now. I don't want to take it during my pregnancy. Lasima, what you will advise her? Give me the vaccine, let me produce the antibodies before pregnancy. Devika, what's the advice? Devika, you are there?
Yes, I'm there.
Yeah. You were practicing in Dubai, I suppose, is it? You were practicing in
No, sir. No. I was practicing in Kerala only.
Okay.
Other PG was in Dubai.
Okay. Now the question is somebody came and asked you, Doctor, no, I don't like to take. It may be doctors themselves, Previously, during maternity, the gynecologist will not allow you to take any medicine, any immunization except tetanus. They were very concerned because the fetus is getting formed. You don't know what will be and there was not much research also because the immuno company might get sued. Therefore, the maternal immunization never came up. But just like neonatal immunization, this is a good cohort which keeps coming back to you. And if you can give something in that and make an impact on certain disease, very, very good. Now, people are really concerned because if you give during, that's what Dr. Anandam also had the back of the mind when she asked me, can we give more vaccines in the my mother? How do you know it won't affect the fetus? We will know it after 20 years. That's what many people will say. Okay, do you think that if you give Tdap before pregnancy, and will it be effective? No, it is not. The Tdap given before pregnancy, you should not give it before pregnancy. It is not effective. If it is given, you will have to repeat it during the pregnancy. Let's come next, please read it.
Tdap contains tetanus toxoid, reduced diphtheria toxoid, and acellular pertussis vaccine. Pertussis is on the rise, and outbreaks are happening globally. The Centers for Disease Control and Prevention reported 307 deaths from pertussis between 2000 and 2017. Children younger than 2 months acquired for 84% of these deaths.
Accounted for
Most of
84%.
these
Yeah. Yes.
Most of these deaths are infants who are too young to be protected by the childhood pertussis vaccine series that starts when infants are 2 months old. To help protect babies during this time when they are most vulnerable, women should get a Tdap during each pregnancy.
Okay, every pregnancy you have to give one Tdap. Now, if it has changed, you read. See, remember.
Maternal vaccines
Yeah, okay.
have the potential.
Yep, read, carry on.
Potential to provide clinically significant protection for mothers and infants. However, the primary aim is for prevention of pertussis in young infants who have disproportionately high burden of severe pertussis. The immunization delivery system globally and even in US has traditionally focused on childhood vaccine. Maternal vaccines against pertussis are not yet recommended in the developing world due to unclear burden estimate and possible infant vaccine response attenuation by maternal antibodies.
Okay. Therefore, they say that, see, this is the first word he is bringing about. Because if the maternal antibodies actually inhibit the effect of the infant vaccines, that's called blunting. That is what one point against giving maternal Tdap. We will come to that in detail as we go ahead. Please understand in the previous slide, it was CDC slide. That means American slide. We had 305 deaths in 17 years of the pertussis. For them, vaccine preventable disease is a huge tragedy. But now remember, there are deaths in the Western world due to measles. Simple reason, people have become so stupid. There's a big lobby which doesn't allow, which doesn't vaccinate their children. Not only they don't vaccinate their children, they attack the people who vaccinate also. Why did you attack your vaccinate your child? Because it will affect them. Therefore, there's a big fight going on. But even in countries like UK and USA, there are epidemics of measles occurring. And therefore, in our places in the government sector, we are not giving Tdap vaccine in the pregnancy. That's definitely what it is. We will come to know that. Now, the general attitude is we shouldn't say anything against the government policy. But the fact of the matter is one way where the private health scores over it. In a very small thing, I would say definitely Tdap should be given. Okay, read it. Can you change?
Vac- vac- Vaccinating women in pregnancy is believed to be protective infant from pertussis in two ways. First, it is likely to increase the transfer of maternal pertussis antibody through placenta and through breast milk. Second, vaccination during pregnancy is likely to prevent maternal infection at the time of delivery, which turn immunize the infant's potential exposure to pertussis.
Okay, because these
Fact about Tdap and
carry on.
pregnancy. CDC number for pre-conception. Tdap
Can't you read it? I can't hear you. Suddenly it goes off the mic. I don't know what's the problem with PRS mic, I think. Can Ashwati read it? Or somebody else? Lasima? Hello?
ഞാൻ CS എന്നുള്ളത്.
Okay, okay.
Okay.
Devika, right?
5 facts about
Yeah.
Tdap and pregnancy. CDC number 4, preconception. Tdap should not be offered as a part of routine preconception care. Protection from pertussis vaccine does not last as long as vaccine experts would like. So Tdap is recommended during pregnancy in order to provide optimal protection to the infant. If Tdap is administered at a preconception visit, it should be administered again during pregnancy between 27 and 36 weeks of gestation.
Let me tell you here that as we go along, that when will you give Tdap? Some actually between 27 and 36 is what the CDC says. UK says 20 weeks. And I think our Tdap, I mean, let's go. Some people said when you see the patient, child pregnant for the mother pregnant for the first time. Okay, now can you read it?
Maternal immunization to prevent infant pertussis.
Yeah.
Safety of Tdap during pregnancy. There are limited safety data on Tdap administration in pregnant women. However, existing Tdap safety data from the CDC, US Food and Drug Administration, and the pharmaceutical pregnancy registers do not indicate any adverse safety effect. Concerns regarding maternal immunization, ultimate titers achieved with a dose of Tdap during pregnancy, duration of maternal antibodies, and finally the interference with proper uptake of the pertussis vaccine during primary immunization due to high concentrations of maternal antibodies. There was some blunting of the response to the infant series, but the children did develop adequate antibodies by the end of complete series.
Are the PRs with me, or Paris, are you with us? I think they.
Sir.
What happened? The net went off, or suddenly we couldn't hear you? Okay. Now come to the next. We are just reading through the slides. Whatever you are missing, you see it through the. Okay, go ahead now. What's the next? This one. Don't have to read the heading. You read the matter.
Okay. The antibody titer to pertussis toxin in acellular vaccine was, however, not affected by the pre-vaccination antibody levels. Further studies are needed to evaluate the impact of maternal antibody levels to primary immunization in young children. If maternal Tdap is to be routinely used where infants receive wholesale pertussis vaccines in the primary series. The result of the study are quite reassuring and add evidence to support the recommendation of vaccinating pregnant mothers to protect their children
Slide change. They protect the children against pertussis.
against pertussis.
Okay. I'm just reading through it because it's self-explanatory. What has come about in the last few slides is that blunting. Blunting of that's why I asked you, is there any point against giving it? The vaccine giving it is the maternal antibodies, the antibodies come and you go and give a pertussis vaccine at 6 weeks, it may not be effective because of maternal antibodies. This is more so, the blunting is more so according to wholesale vaccine is given to when you are giving to a newborn, and we are giving in government sector wholesale vaccine especially. But actually this is basically, I believe it is because of the simple fact that no studies are there in wholesale vaccine, and there are studies in as far as what you call SLR vaccine everywhere. That's the reason, maybe the reason, but it is not. Now, why are gynecologists not giving Tdap vaccine or not 100% in a PRS hospital? Can you read it? Next slide.
Studies suggest
Stunt.
that
Yeah, read it.
studies suggest that one of the main reasons for low immunization rate is clinicians and or women's concern about the safety of vaccine during pregnancy. This precautionary principle centers the approach combined with the risk aversion among legal departments of vaccine manufacturers leads to explosion of pregnant women from the most vaccine trials for decades, leading to gap in evidence of vaccine safety and efficacy among the pregnant women.
Is one of the main reasons people in the pharmaceutical companies were not ready to bring about any medicine for the mother vaccination. They were worried that they will get sued. For some reason they may get sued. Therefore, they did not want to bring in out vaccination, except tetanus toxoid. Nothing else came in the market. Nowadays, they are talking of more and more vaccine being given to the mother, especially influenza vaccine and hepatitis B. Okay. The Indian
The
scenario.
primary immunization.
Yeah. Yes.
Indian scenario. The primary immunization with wholesale pertussis vaccine at 6, 10, 14 weeks of age is followed by a booster at 16 to 24 months and 4 to 5 years of age. There is no national policy for booster immunization of pregnant women or any specific age group beyond 5 years.
That's about whooping
Limited
cough, huh? Okay.
usage
Yeah.
of
Yeah.
usage of cellular pertussis vaccine booster at 10 year and during pregnancy exist in the private sector. The wholesale pertussis vaccine is not offered to older children and adult including pregnant women due to the risk of adverse effects.
Now, the usual DTP, what's the maximum age you can give, Faris? DPT, what we are giving. Maximum age you can
That
give. Let's
7,
see. 7. How much you said?
7.
Okay, 7 is the right time. Remember that this Indian scenario, we give a 6, 10, 14, then at school entry and 4 to 5 years, 1.5 years and 4 to 5 years. After that, we don't give. IAP, I think, recommends Tdap at 10 years, that's all. And then Tdap every pregnancy. In some Western countries, they advise every 10 years Tdap to be given. Therefore, that's the max. Therefore, in India, we are not giving. In the government sector, definitely we are not giving whooping cough vaccine beyond the age of 5 years, and you can't give wholesale vaccine at all beyond the age of 7 years. Okay. Okay, carry on.
Maternal antibodies may interfere with the infant response to routine immunization with the diphtheria, tetanus, cellular pertussis containing vaccine, raising concern of suboptimal protection after infant vaccination. This immunological interference is called blending. This blending has been observed for maternal antibodies acquired after natural infection, but also for maternal antibody included after vaccination.
Is the major issue which you have, because the natural way by which a child protects itself as well as after vaccination is blunted by maternal antibody. Definitely it interferes. But now let's summarize the blunting of antibody response. Is Ashwati there? Can she read it? Because Faris will get tired. Ashwati is there.
Summarizing blunting of antibody response.
Yeah. Read.
Transplacental antibody response.
My God.
Interference with the immune response to the.
Yeah. It's not clear. It's not clear. Devika, can you read it?
Transplacental antibodies
Yeah.
caused interference with the immune response to the pertussis primary vaccination, the effect of which was still apparent before boosting for the 3 pertussis antigens and after boosting for filamentous hemagglutinin and pertussis toxin PT.
Okay.
Conflicting evidence regarding if interference more to DT wholesale pertussis vaccine than DT acellular pertussis vaccine in infants. Indian study shows children of mothers who have taken DTWP primary vaccine in childhood do not have adequate protection.
Let me stop
There
you here. 1 minute is there. There is well known that the wholesale vaccine has a longer protection than the acellular vaccine. Even the Western world has adopted. But what they are telling is, even though it has a longer, it does not have adequate antibodies as necessary for protection. But I am not sure how they are making this statement, because there is no we have already said that there is no protection correlate for whole pertussis vaccine and human papilloma virus. We don't know. The antibodies are not. If the antibodies are there, it doesn't mean that you are protected. The antibodies are not there, it doesn't mean you are not protected. But still, they make a statement. Indian studies show that children and mothers who are taken wholesale vaccine in childhood do not have adequate protection. This is a loaded statement. Is given in the probably in the Indian Purple Book. Okay. There is evidence to delay. Can you read, Devika?
Yes, sir. There are evidence to delay first dose to 3 months and give a reduced 2+1 schedule when mothers are given Tdap vaccine. To delay first dose to 3 months. Currently, there is no epidemiological evidence that the children whose mothers received Tdap are at increased risk of pertussis after pediatric vaccinations. Although longer follow-up is required, there is no increase in childhood pertussis in countries with universal maternal immunization program.
Every sentence is important. We would say that again. Therefore, if mothers are given Tdap, why don't you give the vaccine at 2, 4, and 6 months instead of 6, 10, and 14 weeks when the maternal inhibition will be less? Plus, these are all there in the line. Don't follow it. Don't ever change the vaccination of the National Immunization Vaccination Program. You can be in severe trouble. Therefore, don't do that. But the fact is that there is a point in postponing and giving 2, 4, and 6 months because there are multiple advantages. The inhibition of other antibodies will also be less, and the final dose of hepatitis B you will be giving at 6 months, which is the right way. That's one thing. Now, to people in PRS, in between when you are reading the library of Faris, etc., after one slide, the next slide, the voice goes off. Therefore, I would advise you mute your laptop and read it from your mobile. Therefore, I think that will be better. Then you will get the better. One more slide is there? Can you read? More slide. I can't hear you. I can't hear you. No. Are you reading from your mobile? Okay, but Devika, you read, please.
Nevertheless, these findings warrant monitoring of age-specific pertussis trends in populations with maternal pertussis immunization in order to detect any shifting of the disease burden from infants who are younger than 6 months of age to infants who are 6 months of age or older, as well as to children and adolescents. So slide happened to change.
Yeah, I think it will come back.
Okay. Also. The morbidity and mortality following a pertussis infection in children older than 6 months of age who have a more mature immune system is much lower than in newborns. The benefits of protecting newborns during their most susceptible months of life outweigh the potential risks of blunting later in life.
Okay.
Tdap in the WHO has evolved exhaustive guidelines for administration of Tdap bar TD in pregnant women, which IAP endorse. Unimmunized. For pregnant women who have not been previously immunized, 1 dose of Tdap or TD and another dose of TD at least 1 month apart should be given during pregnancy. The first dose should be administered at the time of first contact as early as possible, and the second dose of TD should be administered 1 month later and at least 2 weeks before delivery. A single dose of Tdap or TD should be administered in each subsequent pregnancy. Fully immunized, 5 childhood doses, 3 primary doses plus 2 boosters, and 1 adolescent booster. Tdap, 1 dose of Tdap is necessary in every pregnancy in the schedule mentioned earlier.
Okay, this is very important that if you have completely immunized, instead of 2 vaccines, you need give only 1 Tdap. Tdap. Normally, you will give Tdap and you will give a TD after 1 month. The second dose is not required if you are fully immunized. Therefore, I don't know whether gynecologists follow this. Why is it that they don't want to give the second dose? Any idea? Now, we will discuss this after what the WHO says. I don't know whether you have now read what is given in vaccinating pregnant women from the beginning, everything. This is the WHO position 2017. Therefore, IAP fully endorses it. Okay, now read it. The whole thing is highlighted. Yeah.
Pregnant women and their newborn infants are protected from birth-associated tetanus if the mother received 6 doses documented by card, immunization registry, and/or history. Vaccination history should be verified in the pregnant women. 6 doses. Following should be applied in countries where MNT remains in
MNT
public
means
health
maternal neonatal tetanus remains a public health problem.
tetanus remains in a public health problem. Pregnant women for whom reliable information on previous tetanus vaccinations is not available should receive at least 2 doses of TTCV, preferably TD, with an interval of at least 4 weeks between doses and second dose at least 2 weeks before birth. To ensure protection for a minimum of 5 years, a third dose should be given at least 6 months later.
That is if you after delivery also you can give. Okay.
Okay, sir. A fourth and fifth doses should be given at intervals of at least 1 year or in subsequent pregnancies in order to ensure lifelong protection.
Everybody should be given 6 doses if it is unimmunized child. Therefore, it is not enough if you have an unimmunized mother to give 2 doses. You have to give the booster after 6 months. Then every year, total 6 doses every person should have taken. Okay. Read the last one.
Pregnant women who have received only 3 doses of TTCV during childhood without booster doses should receive 2 doses of TTCV at the earliest opportunity during pregnancy with a minimal interval of 4 weeks between doses and the second dose at least 2 weeks before giving birth. To provide lifelong protection, a 6th dose would be needed at least 1 year after the 5th dose. Women who receive 4 TTCV doses during childhood or pre-adulthood need only 1 booster dose, which should be given at the first opportunity. To provide lifelong protection, a 6th dose would be needed at least 1 year after the 5th dose.
Yeah, I've written on the left side, very important statement. Childhood and adolescent TTCV only and 1 dose of booster during pregnancy and 1 more after 5 years. What they say is, now let's come back to certain vital points. We have finished the discussion on Tdap. Is the PRS group there or Faris, you are there?
Yes,
Yes,
sir.
sir.
Okay, what's the problem
Yes,
with
sir.
the sound? Is it it is not coming through your laptop, or is it because even when you use your mobile, it is not coming?
Yes,
Because I can hear
issues.
Devika very well from her home. Lasima is there. I think she went off.
Yes.
Anyway, my question is now I started the discussion with asking you a simple question. You can get a full question on maternal Tdap. It's pros and cons. You should know both sides of the blunder. Now, if a gynecologist stops you on the way and says, "Doctor, should I be giving my all the mothers Tdap 1 vaccine?" What will be your answer? Ashwini, what will be your answer? Hello, are you there?
Mother.
The pregnancy,
Vaccine the child.
like Dr. Ananda madam asked me once in a while, long time back, that was about 3 or 4 years ago. She asked me, should I be asking for Tdap vaccine or should I continue with TD? Because the cost difference is very much there. I don't want to give a vaccine which is not benefit. Yes or no? Will you give it or not give it? This is like listening to the Ramayanam, the whole thing, and then asking.
Yes, sir.
Yeah.
Tdap must be given.
Yeah, must be given because they may ask you, doctor, we understand that there are certain problems like blunting of the immunization, newborn infancy. Are you not concerned about it? What will be your answer?
When compared to the
Yeah,
when compared to the advantages of Tdap, blunting is of less significance.
okay. And they might ask you, doctor,
The issues of blunting is
yeah, okay, that's great. The first thing you should say is that the most important thing which will go through it, you must say the WHO says that the IAP unequivocally endorses to give Tdap, and that's there in one of the slides. Am I right? It should register in you. That's why I am putting the reference on the left side. Indian Purple Book, the IAP That's the statement they made. Unequivocally, they are endorsing it. Therefore, that cuts off 90%. Then you can say about blunting. Blunting is something which we should worry about. They shouldn't be worried about. And there might be, among many other reasons, that in private vaccination, you might give it at 2, 4, and 6 months is one of the reasons. If you are given Tdap, why don't start the vaccine at 2 months? But I would say don't jump into it in the present world. Give 6, 10, and 14 weeks also. There are a lot of scientific evidence to say that we should give our child in private practice 2, 4, and 6 months, because for hepatitis B also, we are not giving the final dose at 6 months, which is very, very important. We are giving it at 4 months as per IAP schedule and as per the immunization schedule. Therefore, this chapter is very important. That question is over. And we have discussed it entirely as much as possible. We have discussed it. You can get a short note. They may not ask you maternal immunization because that's not our chapter. They can ask you about Tdap. They can ask you about blunting of my infant response. They can ask you about that. For these things, you should have a clear idea, and you should have no doubts about it. Now, Ashwati, can you read? We are talking about, we have heard about National Immunization Days, isn't it? Pulse polio, right?
Yeah.
Ashwati, have you heard about it?
Yes, sir.
And what happened to Lasima? She has left or what? Mohsen, what do you say? May I ask you, is it, why do you give, we are giving polio regularly. Why do you want to give pulse polio? What is the reason for it? Now, give me an explanation why you want, because
That's for the herd immunity.
it's of course for the herd immunity. All right. How does, I'm just asking Mohsen, how does herd immunity come about when we give pulse polio and does not come about with regular immunization?
Immunize at the same time, sir, or of up to 5 years child.
Okay, then what happens?
So
What happens?
unvaccinated child also will get
Unvaccinated child also will
Yeah.
get, therefore he will get protected. Therefore, you want to vaccinate the children who have taken 5 or 7 doses, again another dose. And so that he would have already spread it, is it not? This child who's you have given 3 or 5 doses of OPV would have all decided. Why do you want to give it at one particular point, everybody below 5 years? Gopika?
to
No, Gopika is not there. Okay.
eliminate
Yeah.
eliminate the whiteboard.
Now, may I ask you a question? Many people talk like this. When you are asked in the examination, these are fundamental questions which can be asked. I know you know the answer, but I know you don't know to answer it in a way that you can't convey it to the examiner. This is what is happening now. Devika, can you make an attempt? Why you want to give the pulse polio? You said herd immunity. He also said herd immunity. I agree with it to a certain extent, but can you go better and explain it in a better way? Because you might be asked to talk about pulse immunization.
So the immunity to one type of polio does not protect against the other type. So
Yeah. So
Eliminate the-
now what type of vaccine are we giving now to the children? Bivalent polio, not the trivalent
Okay.
polio. Trivalent is removed now. It has only 1 and 3. I think it doesn't contain 2. Therefore, type 1, type 3. Type 2 is not there. If I'm not mistaken. Therefore, now, why do you want to give everybody at the same time? We are increasing. Why do you herd immunity? When you give it to the population, naturally, when you give polio vaccination, the herd immunity will go up. Is it not that enough? Now, may I ask you a simple
For
question?
elimination.
For elimination. How does it help to eliminate? There's one more word I want you to say. Now, may I ask you another question? See, we eradicated smallpox, right?
wild polio.
Let me ask you frame the next question to you. Are we recording it? We are recording it, no? We started recording. Okay. Now my next question is, your screen sharing, are we recording? Any idea? Suddenly, recording is in progress, is it not? Okay. Now my next question to you is, I mean, I'm just giving you into fundamental things. Many doctors can know, they will keep on talking of pulse polio, but they may not know the fundamental thing behind it. Now, may I ask you a question? For example, smallpox was eradicated from this world. We are long back. We had because why? We had a live vaccine. It produces very good immunity, and it's a we gave it one dose only at newborn period, and we eradicated. Now measles also, we have a and the other thing for eradication is there should not be an animal vector. There should not be a animal vector. And if there is an animal vector, you cannot eradicate it because you immunize the whole human population, it will still persist in the animal, this one. All these are same for measles and as well as for smallpox, but we are unable to eradicate measles even now. What is the reason for that?
Strains are changing.
What's that? Strains are not
Yes.
changing, Devika. What's it? You must understand fundamental things in immunization.
Immunocompromised.
Who is immunocompromised? No,
Malnourished children are more.
they should have been through smallpox also.
Obviously.
Malnourished children would be immunocompromised against smallpox also. I'm bringing out, you are the consultant pediatricians. When you go, suddenly one day you're working in health service, Paris, the DMO will call and say, Doctor, we are conducting a pulse polio population. There are about 180 health workers coming. Please go and explain to them why and what it is. Very common. And another thing they might say, the police is having a meeting. Because they also have to be mobilized for this. Please go and explain what is pulse polio. They may ask you a simple question, doctor, why don't you give it in your clinic? Why are you giving it 3 days and making all this hullabaloo about it? Okay. Now,
Yes, sir.
yeah, tell me.
So basically, to eliminate the wild polio virus.
Yeah, you're coming closer to it. See, you are increasing the herd immunity above 80% so that the polio transmission stops. The transmission in the community stops. See, once you have immunized and make them immune, the polio virus cannot survive. It goes anywhere, you find that more than 80% of the people are immune. Therefore, that's what happened in smallpox. We vaccinated the the virus which produces smallpox could not survive in the community because it is only in humans it can survive, and most of the humans were. But why are we failing in measles? Measles is one of the most infective viral diseases. Unless you immunize, if you immunize 80% smallpox, you can you can eliminate transmission. 80% polio, probably you can eliminate polio, but there's some other problem which we'll come to that later. But even if you immunize 95% of a population at a time, measles will still survive because it is highly infective. It will survive in the 5% of the population. Therefore, unless you are able to immunize 100% at a particular point of time, which is almost impossible, you will not be able to eliminate measles. But still, we are trying. Now, National Immunization Days, there are about 10 or 15 slides. Some of them are not that important, but you should know everything about it. There are points against it, points for it, and whatever be the scientific points against it, please don't open your mouth about it because that's the National Immunization Program. But you should know it as a pediatrician. Therefore, the next slides we will be going through very fast. You can go home and read it, or when I send you the video, you can go through it. Therefore, as usual, we'll begin with PRS Hospital till they stop talking. Okay, read it.
The primary objectives of National Day. Eradication of polio virus by giving oral polio vaccine at the same time to all children over a short period of time in a large geographic area, transmission of polio virus is interrupted. To be effective, NIDs must achieve high coverage with OPV. Therefore, special efforts are necessary to reach children who are often missed by the routine immunization program.
Therefore, we have to have high coverage. Most important, herd immunity. Herd immunity is there, but transmission of polio is interrupted. That's our aim. Remember this. Okay. Read it.
National Immunization Days of Pulse Polio. The NIDs are necessary in developing countries to rapidly increase the immunity levels in the population to achieve and surpass herd immunity threshold levels for poliomyelitis and hence rapidly interrupt the transmission of polioviruses. The NIDs are conducted twice annually for a period of 1 to 3 days when one dose of OPV is administered to all children less than 5 years of age, regardless of prior vaccination history. A second dose may be repeated similarly after 4 to 6 weeks. National Immunization Days are conducted during the low transmission season for other enterovirus that may interfere with poliovirus seroconversion.
Okay, these are very, very important points. Self-explanatory. I'm not going to. What should write is that 1 to 3 days, same time, so that suddenly the herd immunity goes up and the transmission is interrupted. And during low transmission rate, therefore, you don't do it during rainy season because other enteroviruses may affect. Okay. Read through it.
The target age group. WHO recommends that the target groups for the NIDs is children 0 to 59 months of age. The basis for this recommendation is epidemiologic, as the large majority of susceptible in countries in which polio is endemic are children less than 5 years of age. At the time of planning NIDs in India and China, more than 90% of reported poliomyelitis cases in those countries were children aged less than 5 years. The first NIDs in India in 1995 targeted children less than 3 years of age. The countries choosing lower target age groups such as these risk leaving enough polio susceptible children in older age groups to sustain some chains of polio virus transmission.
Out of interest, I'm asking which state first introduced this pulse polio? It's the capital, New Delhi, and it was Dr. Harshavardhan, who later became the Health Minister of India, who first introduced it, and it had a dramatic effect on the polio in Delhi. Therefore, it was first introduced in India and Delhi in 1995. Okay. Relevance. Read through
Relevance.
it. Yeah.
One of the 4 critical strategies recommended by the World Health Organization for global poliomyelitis eradication and should be conducted in all countries where there is evidence that the polio virus is widespread or where acute flaccid paralysis surveillance is unreliable. When neighboring countries like Afghanistan and Pakistan are continuing to have cases too risky to drop our guard.
Remember that acute flaccid paralysis surveillance is a repeatedly asked short note for you. So please read it very carefully, okay? I may not be covering it, okay? And okay, go ahead.
Duration of NIDs. WHO recommends that NIDs be conducted over as short a time period as possible, preferably 1 to 2 days. The basis for this recommendation is both immunologic and operational. The introduction of a large quantity of vaccine virus in a very short time period appears to enhance the seroconversion rates, probably by passive transfer of vaccine virus to susceptible children. The cold chain can be better maintained for these short campaigns.
Yeah.
Interval between 2 rounds. 4 weeks between vaccine dose is the minimum interval required for seroconversion and to boost gut immunity. The interval between the first and the second rounds should be short enough, that is 4 to 6 weeks. to minimize the possibility that wild polio virus will begin to recirculate between rounds. A related issue is sub-national immunization days, which some countries have conducted to gain the experience before subsequently doing NIDs.
What is subnational immunization days? What does it mean?
Like a monk.
Yeah, subnational means we don't conduct it all over India. We may conduct in Kerala, Tamil Nadu, and Andhra Pradesh. We may not conduct in the rest like that. But it's not very much acceptable. It has to be all over the country because we want to one shot prevent the transmission. That's the most important thing. But as a trial, this is not a simple thing to give every child below 5 years in 1 or 2 days. You had to organize this in the railway station, bus stop, panchayats, schools, everywhere. It's a huge time involvement. Okay. How long?
How long? Pulse immunization to be repeated every year for 3 to 4 years. Most countries conduct NIDs annually for at least 3 years and until polio is eradicated, polio is reduced to focal transmission, at which time the mopping up immunization begins. For WHO and its partners, there was no doubt that the campaign had to continue till the virus was eradicated.
Remember this, WHO wants it to be continued till the, what is mopping up immunization? Can you tell me, Devika? Devika, you are there or gone? I think she's gone.
I'm there, sir.
What is mopping up?
I'm there, sir.
See, during these questions, if I
The
ask you,
one second.
if you don't know the answer, you can straight away say you don't know, so that the time lag doesn't happen. Yeah, Ashwati, can you
Hello?
say? Yeah, tell me. Can anybody answer? What is the
So that is, hello?
Yeah.
Sir,
Yeah,
can you hear me?
Yeah, I can hear you.
So that we target the areas where more chances of polio cases are there. I mean, chances.
Faris, you are joining public health service, PHC, you and Amal are joining, you will become a doctor, you're a pediatrician. When the pulse program comes up, they'll say you are in charge. After the pulse polio is there, they'll say, please do the mopping up immunization. What is mopping up immunization? Mopping up immunization means you will have a list of patients below 5 years, and you will get shown a list in which did not come for the pulse polio. You had to go to those places alone and vaccinate them. That's called mopping up immunization. They say conduct an annually until reduced to focal, at which time mopping up transmission begins. But for WHO and its partners, you should continue the pulse polio till the virus is eradicated. Eradicated means there should be no wild polio, there should be no vaccine-derived poliomyelitis also. Well, that is, we will come to that later. Now, see, when is the country? Read what has come up now.
A country is declared as having eradicated polio if 3 successive years no wild polio vaccine cases are reported and WHO is convinced about the surveillance. Global eradication is achieved only when 3 years elapses since the last case of wild polio vaccine.
Circulating vaccine-derived
Vaccine-derived polio vaccine and vaccine-derived
poliovirus. There's a difference in this. We will come to that later. Anyway, whatever it is, the vaccine-associated polio as well as the wild polio should go away. We will be discussing it about that. That happening seems to be almost impossible now. We will come to that later. We might be, in India, we have eradicated wild polio virus. Is that circulating vaccine-derived poliomyelitis? There's a silence about it. There's not much of statistics. Definitely all over the world, there are more cases of vaccine-derived poliomyelitis than wild polio now. The WHO doesn't want to talk about it. Countries don't want to talk about it for the simple reason that the polio vaccination will become unpopular with the public. I don't know when it is going to explode into the public domain in a country. Therefore, the problem here is till it is over, you have to keep on giving. We don't have a polio in 2011 or something, 2012 or something. We are forced to give the pulse polio. We are not doing it once and twice a year. We are at least doing once a year. And even once a year, I think instead of two, we are only doing one pulse polio. Well, the reasons for doing it, we have already said. Now, there are certain points which are against it. I feel as a pediatrician, you should know about it, but better don't vomit it out in the exam. Your examiners may not like it, but that's a fact. Now come to read the next step. What are the points against?
National Immunization Days against. OPV should not be given to pregnant women, household contacts of the immunodeficient patients. No data are available from developing countries about the duration of mucosal immunity for polioviruses. One study reported that children were completely resistant to intestinal infection 10 years after vaccination. The intestinal immunity induced by oral polio vaccine doesn't persist beyond a year. The immune memory and the vaccine-induced protection is a race between reactivation and microbial invasion. The prompt reactivation of immune memory is not sufficient to control polioviral replication in the digestive tract.
Well, these are the points which I said. But one of the most important points which I have felt very badly is that when the pulse polio program comes, the government is after everybody, especially the health workers, ASHA workers, government sector, to say that it is success. They want to say it is success. It is success only if more than 80% of the children below 5 years are immunized. Every child. There have been instances in which a child has come for regular immunization, and the pulse polio was after 2 days. The mother came and asked me, "Is it to be given?" I said, "Forget it." And the ASHA worker from the local hospital rang up this and said, "We will report it to the DMO, because how can you say, even if it is given today, you should give it tomorrow?" The worry I have is the patients who refuse immunization just don't come for these pulse polios. The rest of the people who comes for the polio, they keep on coming, and we are immunizing the already protected child to protect the unimmunized. And another problem is when you are giving it to a child, you are supposed to make sure that there's no pregnant women at home, and also immunodeficient patients. Many of our families, they have people on severe diabetes who are supposed to be immunodeficient. Patients who are chronic renal failure on dialysis, chronic renal failure not on dialysis, they are all, and many children taking steroids for multiple reasons. And they are all susceptible. We never ask these questions. In the polio program, they never tell the ASHA workers, please ask whether anybody in the house is having renal failure, whether anybody in the house is having cancer and is on treatment. We should not give oral polio. These are kept away just to attain our limits. This is something which I feel very bad about. And further, remember one thing, the child whom you are giving has no benefit, because the child is already given 4 OPV and in a IPV, and there is no report of any child who has received 3+1 IPV to develop poliomyelitis. Therefore, on the top of it, we are giving OPV also, in addition to IPV, which the child doesn't require. And on the top of it, we are firing him with 5 to 10 for pulse polio vaccination. Therefore, these are points which makes me a little unhappy, but you can't do anything. It's a national policy and you have to follow it. Now, what are the other points? Actually, the first opposition for polio came from Kerala, and it's the KGMOA which first made the opposition. Read through it. Read through it fast so that we don't, yeah. Can you read it?
Opposition from states. A routine immunization strategy almost fully covers the under 5 children in the state. This is evident in their reports from the Directorate of Health Services. No polio case had been reported from anywhere the state over 3 years. A child under 5 years of age receives more than 15 doses of OPV by routine and pulse immunizations. The safety of giving such large number of doses is not established. The change in antibody profile and the additional protection offered by the additional doses hadn't been established.
See, in 2010 itself, they came about with this. Okay, the Kerala, as usual, it's the Malayalis who protest, and they did it for the same reason. We have had no polio, not for 3 years, maybe now for 15 years or 18 years or something. We don't have. Therefore, we keep on giving OPV just because. Why should we be giving? Now, next, read through it fast.
The
Okay.
enthusiasm for intensified pulse polio immunization has not been shown for strengthening the routine immunization. Pulse polio immunization activities lasting or 4 days each, twice a year, disrupt the routine work of primary healthcare institutes and their staff. This adversely affects the routine immunization and implementation of other health programs. Such weakening of routine immunization is more dangerous than skipping the pulse polio rounds. One very strong point against the pulse polio initiative is that any number of OPV doses administered to the under 5 children wouldn't prevent the circulation of wild virus in the community. The doctors are of the view that national health programs implemented in the states should have operational flexibility at the level. The state should abandon the current immunization schedule and OPV should be replaced with the inactivated polio vaccine IPV, which is more suitable for communities with a low incidence of polio.
This is absolutely right. We will come into a discussion on this later. OPV, there's a big problem of pulse polio eradication. And whatever these people said is more or less right. Now, it is not only from Kerala, respected, very, very highly respected health secretaries from the center. Her name, she's a lady who even now comes on discussions. I avoided her name because it's not very proper. Okay, what did they say?
Civil servants who headed in the Indian Ministry of Health in 2009 to 10 frequently expressed her frustration to the WHO at the way polio was sucking away resources from other more urgent needs. It completely disrupted the routine immunization campaign. Every 3 to 4 months of the year were devoted only to the polio campaign. This meant those months was not an antenatal care, no antenatal care, no routine immunization done. In theory, these immunization days should have seen polio eliminated after the few years. OPV was less effective in India and other tropical countries than it was in more temperate climates. There were figures showing children getting 10 doses, 12 doses OPV were getting polio. Epidemiologists calculated that even after 15 doses, there was 10% chance of getting polio in UP and Bihar. Campaign fatigue was setting in.
Okay, therefore the government says you have to, WHO says you have to continue this till polio is eradicated. And polio eradication is not on the anvil because vaccine-derived poliomyelitis is now, there's no answer to it unless you stop oral polio and give IPV. And that does not seem to be happening. That's the reason. Therefore, there are a lot of, we have told what is a good thing, what's a bad thing. When you go to examination and ask about pulse polio or National Immunization Day, write only the good thing, because we are not supposed to open our mouth. But have in your back of your mind there are certain problem. But the challenge was dismissed. What is that? Why do people say the other point? Okay, read it.
The challenge being dismissed. FP surveillance in Kerala is poor compared with its counterparts in India, challenge claim. Number of doses of OPV provided to children under 5 years old is clearly within the safety limits. Routine immunization activities are not affected by the initiative. Countries such as Cuba have successfully eradicated polio by this strategy while sustaining high rates of routine immunization. There is no guarantee against virus import from neighboring states.
That's the biggest problem for Kerala, because Kerala, we have a lot of people going abroad, especially to Gulf countries. Plus, remember that in UAE or in Bahrain, there's no polio at all. The polio is there today in Afghanistan, Pakistan, and also in some one or two Mali or some, not Mali, some African countries it is there. One or two are there. Therefore, but still, you have people coming from Afghanistan to the Gulf countries, and some of them might transmit it to Indians and they might come over. Therefore, that possibility is there. We can lower our guard. Therefore, nobody will have the courage to say, let's not give pulse polio. That's a problem, and therefore it goes on and on like that. Therefore, it is true. AFP surveillance in Kerala is poor. I will come to AF. If I divert AF, if I ask you what is AFP surveillance, I'll be diverting already. It is for almost 4:30 here. Therefore, 4:30 there. Therefore, I don't want to divert, but we will talk about it some other time. Therefore, and it is true that it is unfortunately true that the immunization coverage in Kerala is dropping. It is as low as 60% or 70% in Malappuram, especially. Therefore, I have to say this district also. But that's very, very concerning. Very, very, very concerning. They say if there is a case of diphtheria, okay, if there are cases of diphtheria in your state, that means your immunization has failed. Because even if you give diphtheria to about 60 to 70%, diphtheria will not occur. It's a very highly effective vaccine. But we did have diphtheria cases about a year or two back. And the diagnosis of diphtheria is also not that easy whenever we give antibiotic. But in spite of that, we have a very good pediatricians, and you people are also coming up, very good spread of the pediatric population. Therefore, we might pick up every case. Now, therefore, this is the reason they're both sides of the picture. Therefore, how do you summarize it? Can you summarize this?
Summary: Pulse Polio National Immunization Day convinced in
Conceived in
1980s
1980s.
and
Conceived
conceived in 1980s and implemented in 1990s in India has sound significant basis
scientific
and
basis.
did contribute significant scientific basis and did contribute significantly to eradicate polio in many countries, including India. World polio eradication looks a bridge too far now, with the case of wild polio vaccine continuing to be reported. Case of circulating
Vaccine-derived poliomyelitis, poliovirus. Circulating vaccine, yeah.
Circulating vaccine-derived poliovirus are rising, and WHO has no definite strategy in sight for its eradication. Polio eradication and endgame strategy plans of Global Polio Eradication Initiative plan was endorsed in November 2012 by the Strategy Advisory Group of experts of immunization of the World Health Organization and published by the World Health Organization in April 2013.
By that time, they wanted to prevent it, eradicate it by, I think, in 4 or 5 years. Now, nothing of that happened. Okay.
As key component of the plan, it will be necessary to stop oral polio vaccine use globally to achieve eradication because the attenuated viruses in the vaccines rarely can cause polio. Challenges expected for adding IPV into routine immunization schedule, including higher cost of IPV compared to OPV, cold chain capacity limit, more complex administration of vaccine because IPV requires injections as opposed to oral administration, and inferior intestinal immunity conferred by IPV.
Okay. Therefore, there are two options options available. Plan A.
Plan A, continue the pulse polio till the world is eradicated of polio. For this, whole world should not have a single case of VP, WPV and CVDPV for 3 years.
Wild
Plan
poliovirus
B,
and circulating wild
strengthen
polioviruses, circulating vaccine-derived poliomyelitis for virus for 3 years. Okay. What is plan B?
Strengthen routine immunization, AFP surveillance, introduce IPV, and seek alternative strategies. Stop pulse polio. If case reported, do mopping up immunization in local areas. Alternate strategies require open discussion and somebody taking charge. Who should take the lead? The Immunization Authority Committee of IAP recommended
Immunization Advisory
pulse
Committee of
polio
IAP
use.
recommendation. Advisory Committee. Okay.
IAP recommended pulse polio use in the country in 1989.
Yeah, but they should naturally take the lead, is it not? They actually made this pulse polio into India. Therefore, there is an ethical question basically on it. You are giving already what you already received 3 doses of IPV and a booster. What's the point in giving again and again and again OPV to these patients? It is of no benefit to him. You are giving it for other children, which you are not disclosing it to the parents. Okay, there's an ethical problem. Many people have openly started recording it, and that's the reason. Therefore, this is to give you I spent a lot of time on pulse polio because you should have a very good knowledge about it, where we stand about it. Many questions will come again and again. If you are in the health service, don't open your mouth anything against it. But in your mind, keep understand this pulse polio, there's a question mark whether Kerala should be continuing it, how long to continue it. That's the basic problem in this. Therefore, with that, therefore, suppose, I ask Ashwati, suppose you are asked to write a short note on short notes or on National Immunization Days. What will you write? Can you offhand say what will you say? Ashwati, you're there or gone? I can't hear Ashwati. Devika, can you give me an answer? Hello, you're there? Can you hear?
Yes, sir.
Yeah, Devika, what would be the summary of because I gave so much information, you will
Yes,
find
sir.
hardly anything written about it in the
Sir.
textbooks. People don't want to discuss about this. That's a basic thing. If you go to an IAP meeting, they will not discuss about pulse polio. They will not discuss because anything concerned government strategies, if there is any point which is not scientifically backing it, they will never discuss it. They're afraid. Therefore, here I would like to ask you what will be your final impression on this? Pulse polio, we will have to continue because that's a government policy. Is it right? It's difficult to say what is right and wrong because we don't want any polio. A good number of patients are not coming, not taking polio vaccines. And the right way would be to immunize, strengthen our immunization, switch over to IPV. We should find money for that. Instead of it, we are continuing with an OPV, which can produce vaccine, circulating vaccine-derived poliomyelitis, and which is responsible for majority of the paralytic poliomyelitis now. And we are continuing to give half-hearted pulse polio. What do you mean is, once in 2 years or 3 years, we have one dose, 3 days we give pulse polio. That's it. It is not 4 to 6 weeks apart. You are supposed to do at least 2 every year, minimum 1. Two times every. That is, you give today in June. If you give it in, say now in July, you will have to give exactly 1 month later another pulse. We are not doing it. We are supposed to do it twice a year. That is every 6 months. We are not doing it. Therefore, we are making a half-hearted attempt at pulse polio, and we are not sure about the results. Anyway, now I leave the chapter. You can read through it again and come to your own action. Some of the things which I have written about what the Kerala government said and the central government said, don't repeat it anywhere because you are not supposed to talk against the national policy. That's definite. Okay, now antibody vaccine reaction. Can you read through it now? May I ask you a question, Dr. Ashwati? Did we have a Kawasaki recently?
No, sir.
You didn't have it. You had a doubtful case. Suppose there is a 7-month-old child. Now you had a Kawasaki and you gave him immunoglobulin. At the time of discharge, what will you advise him? 7-month-old child. He came to you with Kawasaki. You made a brilliant diagnosis. You gave him immunoglobulin 2 gram per kg. You sat in the PICU with him, gave him, and you did a post echo. Everything is fine. You did a fantastic job. You are writing the discharge. What will you be telling him?
Vaccination after
Yeah.
vaccination is advised only after 4 weeks or 8 weeks, sir.
Which vaccine?
Live vaccines.
Okay, which is the live vaccine you and I give? 7 months, which is the next live vaccine.
Please. MMR.
MMR.
Yep.
Deepika, where you practice so far? Which hospital? Ashwati, what do you say? You also practiced outside before you came here. Before when you discharge, even now in PRS hospital, you are discharging 7 months. You are discharging a patient with after having given immunoglobulin. I know Purnima and others would emphasize this to you. Remember this. I'm sure she will not miss it. But may I ask you, she said about the live viral vaccine. The live viral vaccine, which we normally give, is MMR, which is due at 9 months. And according to Dr. Gopika, who is a diploma in childhood, she says don't give it for 4 weeks. Normally, we never give it for 4 weeks, is it not? We give after 4 weeks. Can you give the 9-month dose? Mohsen,
So you can repeat, can give it.
can you give or not give at 9 months? All right.
Can be given it.
Can be given at 9 months. Okay. What does
Bit of
huh? All right. Now read it and let's come to it. It's very clear that your knowledge is you are at ground zero in your knowledge about antibody. This is a very practical thing. Very practical thing which on immunization. You require a primary as well as booster dose and recurrent boosters for your knowledge. I'm telling you. Now read it very fast.
Immunization in relation to antibody containing products. Whole blood packed red cell plasma or immunoglobulin. Blood example, whole blood packed red RBC and plasma and other antibody containing blood products like immunoglobulin, hyperimmunoglobulin and IVIG can inhibit the immune response to live vaccines such as measles and rubella vaccines for 3 months or longer. The effect of blood and
Gone. I don't know what's the problem with from the
effect of blood and immunology preparations on response to mumps and
Recording in progress.
okay.
However, commercial immunoglobulin preparations contain antibodies to these viruses. Other live vaccines such as typhoid, type 21A typhoid, rotavirus, yellow fever,
Live attenuated influenza virus.
and Zostavax vaccines administered at any time before, concurrent with or after administration of any immunoglobulin, hyperimmunoglobulin or IVIG.
This I was not aware of it, that yellow fever can be given anytime. Rotavirus is oral, therefore you can give. Typhoid live vaccine, we don't give. Live influenza vaccine is also not usually given. I am not too sure whether GG hospital is giving. I don't think PRS is giving it. Therefore, therefore we are mainly concerned with MMR vaccine, measles, mumps, and rubella vaccine. Therefore, that's where the inhibitory effect of immune response to live vaccine, measles and rubella vaccine for 3 months. That's what they're telling when you give a blood product. But we'll come to that later. Go ahead.
The principles of antibody vaccine.
Yeah.
Live vaccines must it in order to cause the immune response. Antibodies against the injected live vaccines may interfere with replication. If a live injectable vaccine like measles, mumps, and rubella, varicella, or combination of MMR or varicella, MMRV must be given around the time that immunoglobulins are given. The two must be separated by enough time that the antibodies do not interfere with viral replication.
There's one thing. What about the next one?
Inactivated antigens are generally not affected by the circulating antibody, so they can administered before, after, or at the same time as the antibody. Simultaneous administration of passive antibodies in the form of immunoglobulin and the vaccine is recommended for post-exposure prophylaxis of certain diseases such as hepatitis B, rabies, and tetanus.
Okay, this is a very important point. Previously, they used to say you can't give the antibodies and the antigen together because they won't be effective. But in certain conditions, which has a short incubation period, um, they like tetanus and rabies. Rabies can have an incubation period of 5 days, or it may have even 5 years. Can be quite varied. In tetanus, it is very well known that by the time your tetanus toxoids start acting, sometimes the tetanus would have already set in. And hepatitis B, we are concerned of maternal transplacental transmission, not what you get by a skin prick and all that. Therefore, now in these you administer both the immunoglobulin and together, with the hep immunoglobulin together, but at different sites.
Therefore, administering inactivated vaccines and the toxoids either simultaneously with or at any interval before or after the receipt of antibody-containing product should not substantially impair the development of a protective antibody response. Exception is administration of rabies immunoglobulin, RIG, 7 days after rabies vaccine. The vaccine or toxoid and the antibody preparation should be administered at different sites using the standard recommended dose. Increasing the vaccine dose volume or the number of vaccination is not indicated or recommended.
Let me tell you one thing here, that once you have, see, the point in rabies is very funny. We will have to go into discussions very much slowly into that. Now, if you have given rabies and if you have to give immunoglobulin, you should give it immediately. Sometimes the immunoglobulin may not be available. In India, monoclonal antibodies are available, but they are all costly. In the government sector also, the supply at times becomes a problem. If you have to give, therefore, you have to go ahead with the giving the rabies vaccine. You give the rabies vaccine, you don't give the rabies immunoglobulin, you will have to give it within 7 days. On the 8th day, if the immunoglobulin comes, you are not supposed to give it because your vaccine antibodies are peaking, and that your vaccine will become not effective. Therefore, more than 7 days after that, you are not supposed to give the immunoglobulin. But inactivated vaccine and toxoid, and if administering inactivated toxoid either simultaneously before or after receive the antibody containing product, no problem. The whole problem is only with live vaccine. The exception of an inactivated vaccine where immunoglobulin has some restriction is rabies. Okay. Therefore, the question is there are certain things of rabies immunoglobulin is given only once in a lifetime. If you are given immunoglobulin once to your child, you will not repeat it again, and even if he gets another bite. And the other thing is, once you are given the vaccine, you cannot give the immunoglobulin after 7 days. But suppose a patient with rabies, he is bitten by a dog and he comes after 20 days. You are not given vaccine, you are not given immunoglobulin, you can give both. These are important points in the rabies vaccination. Okay. All right, read it fast.
Although the passively acquired antibodies can interfere with the response to rubella vaccines, the low dose of anti-ROD immunoglobulin administered to postpartum women has not been demonstrated to reduce the response to rubella vaccine. Because of the importance of rubella and the varicella immunity among women of childbearing age, the postpartum vaccination of women without evidence of immunity to rubella or varicella without MMR or varicella vaccine should not be delayed because of receipt of antiglobulin or any other blood product during the last trimester of pregnancy or at delivery. These women should be vaccinated immediately after giving birth and, if possible, tested more than or equal to 3 months later to ensure the immunity to rubella and measles.
Very interesting. This is given in the IAP Purple Book. Therefore, this is the IAP's chapter. Okay. I never knew that it was so important that should be concerned about varicella and rubella immunity to mothers. Therefore, what it means is, if tomorrow PRS hospital mother comes to deliver, we are supposed to ask her whether you have been vaccinated against varicella or measles or rubella. And if she has not been vaccinated and she did not have chickenpox, we are supposed to test her antibodies and give her the vaccine before she discharges. Well, as a senior pediatrician, I didn't know about it. I think if it is given in a IAP test book like this, when you start your practice in whichever hospital, you must be talking to the gynecologist and telling them, informing them, this is what is given in a book. It's better that, see, now the mothers who come here, they want the best of medical care and they are ready to pay for it. And these are all evidence-based recommendations. Therefore, whenever you read it and it is not being practiced, it is up to you to now take it up with these matters. All right, now let's go to this is guideline for, you have to read it very carefully. There's a table as it happens. Tables always contain so much information that sometimes you might miss it. Ashwati, can you read it from the top? You have to read on the left side only. What is written on the right side? You forget it now.
Type of Table 6 guidelines for administering antibody containing products and the vaccines. First, the type of administration. The simultaneous during the same office visit. The products are antibody containing products and the inactivated antigen. Recommended minimum interval between doses. It can be administered simultaneously at different anatomic sites or at any time interval between the doses. Then antibody containing products and live antigen. It should not be administered simultaneously. If simultaneous administration of measles containing vaccine or varicella vaccine is unavoidable, administer at different sites and revaccinate or test for the seroconversion after the recommended interval.
Okay.
Then the type of vaccine which is
non-simultaneous. Okay.
non-simultaneous, administered first, and the recommended minimum interval is
administered first antibody containing product, and the second and the administered second inactivated antigen. No interval is necessary. Administered first inactivated antigen, antibody containing interval, no necessary. That is, if you give a DPT today, you can give a blood transfusion tomorrow, no problem. If you give blood transfusion today, 3 days later, you can kill the vaccine, no problem. But antibody containing product first, that is where the problem, live antigen is where the problem arises. Therefore, all the problem arises with live antigen. If I give a blood transfusion today, when you give a live antigen is the question. Antibody containing product can be immunoglobulin, like you gave in Kawasaki. And even the qualified pediatrician like Devika said, 2 months, it's a big mistake, I'm telling you. And if you give a live antigen, the antibody containing product, you should not give for 2 weeks. That means if I am giving measles vaccine today, and for 2 weeks, I am not supposed to give the child a blood transfusion, or I am not supposed to give him an immunoglobulin. Now, this has happened to me because sometimes you give the measles vaccine, the child develops a fever and rash and erythema, and sometimes conjunctivitis, and you are doubtful whether the measles produced it or the child has developed a Kawasaki, and it continues to have fever, and on the 7th day and CRP rising, you are in for trouble. Therefore, you will have to give measles immunoglobulin, thinking it is Kawasaki, then the live vaccine will have to be repeated. Therefore, if you suppose you are giving antibody containing product, that's what I asked. Like, what will happen? When can you give the live antigen? That's the question I asked you. You gave me the answer. Now let's go. Therefore, the issues are only with live vaccine. Remember this. When you give blood transfusion, blah, blah, everything is only with live vaccines. Now we'll come to what is given in the left side. Can you read it? You had to read the whole thing.
The recommended interval between administration.
Yeah, read it. Well, it's gone.
Containing products and measles virus containing vaccine by product and indication for vaccination. First, the product of the indication. Tetanus immunoglobulin.
Let me tell you one thing.
250 unit.
1 minute, Ashwati. You can go home and read the whole table, but it is not possible to remember. But certain things are very important. The last column is recommended interval between measles before measles containing vaccine or varicella vaccine administration. Okay. Therefore, you can give it how many months before the measles vaccination. Now, what you give, I have highlighted, we are giving tetanus immunoglobulin, hepatitis A, sometimes hepatitis B, definitely rabies, varicella, all are important. Okay, you read through it now. Tetanus. Okay, Dr.
Tetanus
Ashwin.
immunoglobulin.
Yeah.
250 units, 10 mg per kg.
Forget the dose of the
Immunoglobulin gram per
forget the
kg.
dose of the immunoglobulin. Just read the months. You are giving tetanus immunoglobulin today. 3 months you cannot give measles or virus. Hepatitis A, 3 months. Hepatitis B,
Hepatitis
3
A.
months. Rabies, 4 months. Okay. Varicella, 5 months. Measles, we don't give much, but 5 and 6. What comes now is the problem of blood transfusion. The next slide will show you about immunoglobulin. Now, the packed cells which we are giving here, are they washed or are they not washed? Mohsen, I have asked this question to you before. Are they washed RBCs or are they not washed RBCs? Devika? Mohsen, you are silent. Ashwati, what do you say? Have you given a 2 days ago before I heard that you were giving platelet transfusion? Okay, you gave a platelet for a dengue.
Yes.
How old was the child?
Better, sir.
Huh?
Better.
How old was the child?
9 year.
9 years. Okay, therefore there's no question of giving him a vaccine which is, though MMR is given in some patients at 10 o'clock with 10 years, we don't give. Remember here very carefully, I will just mark it out for you. I want to emphasize certain things which are very important. You see, you can see RBC washed 10 ml per kg negligible, therefore you can give none. That means you can give immediately after that the vaccine. Now, when I ask you a fundamental question, when we give a packed cell, is it washed or not? You are not knowing. Now, the next time when you come on Wednesday next, please go to the blood bank and ask the doctor, are we giving washed RBC or not? Because if we giving washed RBC, we can give the live vaccine immediately. For 7-month-old child, you are given some blood transfusion, you can give the MMR. But if you are giving just adenyl saline added, not washed RBC, 3 months you can give. Packed cell RBC, packed RBC, okay? That's what I think you are giving. 6 months you cannot give the live vaccine. Whole blood 6 months. Platelet product 7 months. Therefore, if you had given platelets to your child was not 9 years, but was 7 months. Another 7 months, you cannot give him the MMR vaccine. Remember this. Okay. Now, this slide, this must be in your hand. Whenever you are given immunoglobulin, blood products, immediately think, when can I give the MMR vaccine if he is due for it? Because we are giving MMR at 9 months, 1.5 years also. And are we giving a booster at 5 years? I don't think we are giving. Therefore, you have to know this very carefully. Now, this comes to the IVIG, the question which I asked. Okay. I would ask Devika to read it. Devika, can you read it? Interval before measles containing vaccine or varicella vaccine administration. the product of IVIG. Remember this. Can you say that? Hello, are you there? Ashwati, can you read?
Replacement
Yeah. Go ahead.
replacement therapy for immune deficiencies. Interval 8 months. Immune thrombocytopenic purpura treatment 8 month interval. Prophylaxis post exposure varicella prophylaxis 8 month interval. Immune thrombocytopenic purpura treatment 10 month interval. For Kawasaki disease 11 month interval. For monoclonal antibody to respiratory syncytial virus, no interval needed. For cytomegalovirus, immunoglobulin, 6 month interval.
See, what is important here to know is it dependent on the dose of the immunoglobulin you give. The maximum dose is given for Kawasaki. It is 2 gram per kg. 11 months you can't give the vaccine. Therefore, if you are giving a 7-month-old child, 11 months he will not be taking the vaccine. Otherwise, what else you can do is you can give the MMR and repeat the dose after 11 months. There are two. Therefore, you will have to discuss it on a varying period. That's why I asked you. And there is a problem regarding replacement immune therapy for immune deficiencies. What's the problem? 300 to 400 milligram per kg every month. You have to give it every month. Suppose you have a Bruton's disease, IgG deficiency, lifelong, you will have to give him immunoglobulin. When can you give the measles vaccine? The problem is that you may give the vaccine, you may look for the antibody titer, it may not be there. If he gets exposed to measles, you will have to give the IgG, measles IgG. So these are issues. Remember this, Kawasaki 11 months is the highest. ITP, some people give 2 grams. If you give 2 grams, it is dependent on the dose. Okay. Remember, this is a very important point, and I have spread it out very much. Now, one thing which you should remember here, which I want you to know, is monoclonal antibodies against RSV are there in the Western world. I don't know why it is not there. Last time I inquired with Dr. Karthik, he said it's not available in India and they don't consider giving it. And RSV is not a major problem as far as we are concerned. So that's the answer he gave me. And therefore, monoclonal antibodies, no. Remember, in rabies, monoclonal antibodies are there. Therefore, if you give monoclonal antibodies, there is no problem of giving live vaccines afterwards. Okay. Monoclonal antibodies are there. Now they are trying to bring monoclonal antibodies even for snake bites. Therefore, now other than this, sometimes illness becomes a problem. You understand? A child is having fever with cough and cold, and he comes to you, he's unimmunized. Dr. Faris, you are sitting in a health center. Will you immunize him or not immunize him? He's due for immunization. He comes to you. He's having cold and cough. And he's already due for immunization. Not only due, he has missed the immunization date. Faris, give me the answer. Devika, you
Yes,
can
sir.
get. Yeah. Why you're taking so much time? If you don't know the answer, tell me I don't know. Because we are wasting time. Okay. Any idea?
After subsiding fever.
After subsiding only you will give. Anybody else is against that point? Anything?
It's a mild cold and we can give some.
Mohsen, you are very good. You are a conscientious pediatrician, but I don't know whether you are on current with the present time. If you practice defensive practice, you may not give it. Now let's read about it fast. Okay.
Interference might occur if administration of an antibody containing product become necessary
Okay, we are
after
going. We are not finished
administration
the
of
point. Yeah, Vasil. Okay.
Usually, vaccine virus replication and stimulation of immunity occur 1 to 2 weeks after vaccination. If the interval between administration of any of these vaccine and subsequent administration of antibody-containing product is less than 14 days, vaccination should be repeated after the recommended interval, unless serologic testing indicates an appropriate
A protective antibody.
appropriate
Sorry,
immune
it's a
response.
protective antibody level. Okay. Now, my question here, this was the previous one only. We were talking about the blood transfusion, then the live vaccine. The other way around. You are given the live vaccine, you are forced to give a blood transfusion or an IgG within 22 weeks, then you will have to repeat the live vaccine. That's the answer to it. Now, I read this in during illness.
Immunization during illness. Immunization during acute illness may lead to lower immunity or vaccine failure. Hence, vaccination should be postponed in a moderate to severe acute illness, and parents instructed to return for vaccination when the illness resolves. Vaccination is also postponed to avoid superimposing the vaccine reaction on the underlying illness and to mistakenly attribute a manifestation of underlying illness to vaccination. However, vaccination opportunities should not be missed during minor illness such as upper respiratory tract infection, mild diarrhea, or otitis media.
This is called double talk. You understand the problem is, I would advise you not to give. The reason why they say that you should not miss it in upper respiratory tract, mild diarrhea, and otitis media, one of the principles to in practice of medicine is every contact with the patient, use that opportunity to maximum uh, improve the public health as well as immunization, other preventive measures, everything. If a patient is coming to you with something else, cold and cough, and she's a lady, you might have to ask her about IUD, etc. I mean, how about the pregnancy prevention, etc. You're supposed to use that opportunity because when during a contact with a healthcare worker, the person is more receptive to you. Therefore, there is nothing wrong in giving an upper respiratory tract infection, especially if he doesn't have fever and immunization. And we used to practice it in Oman. But back in India, I wouldn't. The present problem is he comes to you with a mild diarrhea, you give an immunization, and the patient gets a Guillain-Barré or some other complication. They will attribute it to the vaccine. And it is not only not good for you, it is also not good for vaccination. But you will have to wait. Therefore, if you have a child coming in a place where they will not come back to you again, unlikely to come back for immunization, you can use the opportunity to continue it. But from a defensive practice, it's better not to give the immunization. And there are theoretical reasons why you shouldn't do it. Therefore, it's a double talk they are given in this. What about bleeding disorder? Read through it fast.
Immunization of children with bleeding disorders or those receiving anticoagulants. Person with bleeding disorders such as hemophilia and person receiving anticoagulant therapy are at increased risk of bleeding after IM injections. When vaccines recommended to be given only by the IM routes are to be given. Vaccination can be scheduled shortly after administration of clotting factor replacement. A 23 gauge or similar needle should be used for vaccination. Firm pressure without rubbing should be applied to the site for at least 5 to 10 minutes. Alternatively, vaccine recommended for injection could be administered subcutaneously to person with bleeding disorder if immune response and clinical reactions to those vaccines are expected to be comparatively com- comparable by the either route of injection, such as HIV conjugate vaccine, IPV, PPSV.
Polysaccharide pneumococcal, I think that's what is vaccine. Now here, this is the many things are there, see, what is very important is you give the vaccination immediately after you give the hemophilia, after you give the anticoagulant, next day you come and give the vaccine. Now, there is many problem. Remember that this 5 to 10 minutes, which they have written here, is very important. 5 to 10 minutes is a long time. You have to keep it pressed. Don't rub it. Don't remove and see whether there is thing. Keep it pressed. 5 to 10 minutes is a long time. Similarly, when a dog is bitten, wash the wound for 15 minutes. It's a long time. You have to do it. Now here, the last one where I have underlined is, this is typical of the purple book of Indian Academy of Pediatrics. They don't know what they write on one side. They don't know what is given, and mistakes are written everywhere. They are clearly written that in the routes of immunization, that subcutaneous vaccine, you should not give killed vaccine like conjugate vaccine or IPV or pneumococcal vaccine. It can only be given for viral vaccines for which the presence of lymphatics, the dendritic cells are not important. Here they are telling vaccines recommended for injection could be administered subcutaneously. How can you administer that? To person with bleeding disorder, if the immune response and clinical reaction to these vaccines are expected to be comparable by either route of injection, it means that HIP vaccine, conjugated vaccine, IPV, etc., can be given subcutaneously. No. If you go back into the purple book, go back into the route of immunization, you will find them clearly written. Viral vaccines are the ones which are given subcutaneously. This is a problem with the purple book, and we can't do anything about it. The right hand doesn't know what the left hand writes. They don't edit the book properly. In a book which is considered the flagship book of the Indian Academy of Pediatrics, they are talking of immunization. Other than all of the books, this is the most important publication which they can bring, because for immunization, even today, right or not, the general practitioners, the doctors, the public health people, everybody look up to the pediatrician for the final answer. And therefore, I don't think this statement is right. I don't think that the subcutaneously given HIP vaccine is effective. Anyway, that's my point of view. We'll stop the discussion here. We will continue on the next. We have only finished half of the slides of this one. Any question you want to ask? Hello? Anyway, I will distribute the individual vaccines which you should prepare by this weekend. Start preparing for vaccines, because there's not much time left. I might, as I've told you already, I would prepare certain vaccines like polio vaccine, pneumococcal vaccine, rabies vaccination, etc. The other vaccinations are very well given in the purple book. You might require here and there some addition or subtraction. And there are certain gross mistakes like what they have written here also. Thank you. Thank you for that. Any questions you want to ask?
Yes, sir. Thank you, sir.
Okay, see you
Awesome.
next Wednesday then.
Thank you.
Bye.
Thank you, sir.
Stop the recording. Screen sharing is stopped. Okay. Now ask you. I don't know where it's going.
Yeah.
All right. Bye.